Welcome to the Dusty Muffins, where menopause meets sisterhood and strength. We're three menopause specialists coming together to laugh, share, and empower you through the wild ride of menopause and perimenopause. Whether you're curious, confused, or just looking for real talk, you're in the right place. We're here to answer your burning questions, educate, and advocate, all with a dash of humor and a lot of heart. So pull up your chair and join the conversation. Before we dive in, please remember, while we're doctors, we're not your doctors. This podcast is for educational purposes only and is not a substitute for medical advice. We encourage you to partner with your own medical clinician to address your unique health needs. This is the Dusty Muffins.
I am Dr. Rebbecca Hertel. I'm a board-certified osteopathic family medicine physician and a Menopause Society certified practitioner. I have a private telemedicine practice, and I see patients in several different states.
I am Dr. Aoife O'Sullivan, a board-certified family physician and Menopause Society certified practitioner, and I see patients through my telemedicine practice here in Oregon and Washington.
I'm Dr. Hart Kress, a board-certified women's health nurse practitioner and menopause certified practitioner, and I see patients via telemedicine in several states as well.
Hello, muffins. Welcome back to the pod and the tray of muffins for all of you. I'm Rebbecca.
I'm Christine.
And I'm Aoife. Today's episode is one we've been wanting to bake for a long time. We're talking about why powering through pain during sex is a recipe for disaster and what's actually happening under the hood, literally.
Our guest today is the brilliant Dr. Andrea Martin. Andrea is a board-certified women's health nurse practitioner and earned her doctorate in nursing in 2018.
She's a powerhouse in the field, an active member of both the International Society for the Study of Women's Sexual Health and the Menopause Society. She's also the founder of Glow Health, a telemedicine practice serving Pennsylvania, New Jersey, and Maryland.
And if you follow at Andrea Sexplains It All on Instagram, you know she's as relatable as she is smart. Andrea, welcome.
Oh, you guys are so nice. Shucks. Thank you.
We love it.
We're so happy to have you.
Yes, especially today, right? So at the time of this recording, it is the snowmageddon across the country.
Yes. It's a little bit of a blizzard outside my window.
Yeah.
I know, it worked out perfect.
Andrea and I are both in you're in PA, right? Near Philly?
Andrea, yeah,
right?
So we're like opposite ends of the state.
Yeah.
It's still ridiculous to me that we're in the same state because it feels like you're in another universe because
I know
our stupid state is so wide.
It's so wide.
She's wide set.
Yeah, she really is. I think it's about a 6+ hour
hours.
I think, to you. Yeah,
I believe so.
So
yeah, it's closer for you, Rebbecca, to go to Ohio or New York than to go see Andrea in Philly.
Yeah, it may. I don't know. It may even be a touch closer for me to see you, Christine, too.
Wild.
Maybe about the same because it was about 6 hours when Lexi was in DC. So,
It's all how you get there.
Exactly.
Well, Madam Andrea, we have to start with that legendary clitoral wallpaper. You have this literal wallpaper in your house, and I have to know, why clitoral wallpaper? And more importantly, how did your husband feel about that being a permanent fixture in your home?
Why not clitoral wallpapers, would I say? I think more of us should have clitoral wallpaper. I just love it. It's my favorite part of the body. I feel like it's underappreciated. And it's just fantastic. So when I found that, my head about blew off, and I was like, I need it now. And there's no convincing with the husband. He's totally on board. This room is like the first room you hit as you enter my house. So he loves. I know he loves quizzing people, and he makes everybody stand in this room and ask them if they know what it is. The stats aren't too good. Let me tell you.
What do you think? How many are yes, they know?
Oh God, not many.
Like, is it a fork?
Exactly. They're
like, a wishbone?
We'll get a lot of like, I feel like it has to do something with ladies or their parts judging by like context clues from the other things around. But he brings everybody right in.
I think that's amazing. I think that's really awesome. Yeah.
I know. He's from North Dakota, and we had someone over the summer, I think, like someone's daddy grew up with, which is like salt of the earth, like North Dakota farmer. And he brings him right in, and I was like, oh God, leave this poor old man alone. And then he loved it too. They had the whole conversation. He's like, what do you know? That's a clitoris.
I love it. Do you
I
think that sometimes like guys know they know what it is even sometimes over the females? I feel like when I quiz some of like my friends, the guys are like they know they'll come right off on it.
Yeah, well in my case almost nobody knows who it is, but it's pretty standard across the board, men, women, that nobody knows what it is. So
The only part of the human body that has no function other than pleasure.
I know, we don't even know what she looks like.
No. Well, that's because what was it? 1999 before it was actually published in any literature and they had mapped it out. I forget who the doctor is that
I know.
figured her out, but it seems like that was very recent, right?
Very.
Like 1999 was not that long ago
No.
for human anatomy.
No, and then it was only like, what, 2 years ago that we found out how many nerve endings are in the clitoris
Yeah,
because
I
we were
remember that.
going by bovine studies, basically. We
Yeah.
studied
That was
cows.
2 years ago?
It was 2 or 3 years ago,
Yeah,
that we found
yeah.
out there was 10 to
I remember that.
11,000 nerve endings in the clitoris.
Endings, yeah. And I think it's incredible too when you start asking even just a younger population, like, do you know why the clitoris is located where it's located? I mean, even like our under 30 population that maybe we talk to, if we're doing pap smears and we kind of talk to them about that. And we ask, I'll ask if they use a, intimate device or a vibratory device. And they're like, and I'm like, well, that most women don't climax during, penetrative intercourse. And they're like, oh, I mean, our older generation too, but I think those young ones, that are like,
Yeah.
is there something wrong with me? Because, they're watching these women, pretend that this is happening if they're watching pornography. Right. And so then you say to them, well, it's on the outside for a reason because that goes first. So you are supposed to climax first, which then allows the vagina to accept a penis. And the whole light bulb is like, it elongates, gets moist, right? All the things so that you can have penetrative intercourse. And the whole light bulb goes off, I feel like. They're just like, holy cow.
Do you see that all the time, Andrea? Oh, sorry, where women come in and think there's something wrong with them?
Constantly. Yeah. I also get a lot. This is where I think faking orgasms hurts not just women, but men too, because I'll get people who say, like, my partner sent me in because they said his last girlfriend or whatever, she would orgasm all the time from just his penis and this and that. So he said there's something wrong with me. And I'm like, okay, maybe she is one of the people that, orgasms.
One of the 10%ers.
Exactly.
Right, rare.
But statistically, I think she was pretending, and now he thinks he's like this amazing God, and there's something wrong with you. I'm like, there's nothing wrong with you.
Yeah.
We're going after the wrong parts. Vaginas are sometimes just like these stupid tube socks that are just like there, but like they're just like, okay. And then the clitoris is like, guys, I'm right here, and everyone ignores her.
Right. Well, it's kind of like that whole, when we talk about hormones, right? Estradiol, everybody thinks is like, the center stage, but really the real hero is testosterone. It's the same thing with sex. Everybody thinks it's the vagina, but it's the poor forgotten clitoris. Or in your case, right? We decided earlier that it should be clitori and not clitorises.
Yeah,
I know.
We prefer that.
Right.
We're very uncomfortable.
And do you feel like, I would rather say to my partner, when it comes to, if I'm just like, I'm not in the mood, we want to have sex, that's fine. Instead of faking it, I would just rather say, you know what, we're just going to be intimate, and
It's gonna be a cheap talk.
really don't feel like orgasming and climaxing, and it's fine, and it's okay.
Yeah.
Like you know what I mean? Because sometimes that's fine. If you're just like, let's just kind of do a quick thing here, and like, I'm going to be fine with being intimate here, but I just don't. I mean, half the time, you get into it, and then you're like, okay, fine, maybe I should, but
if I must. Yeah,
no, I must do it.
It helps no one. It literally helps no one.
Right.
To lie.
For that exact reason. I'd rather just be like, just be honest with your partner and just say, I can't, or I'm not in the headspace to do that, but I can still be intimate with you.
Yeah. And how is he supposed to know if you've been for years and years and you're like, yes, that one thing, that is perfect. In reality, you're like, not doing it for me.
All you had to do is like move that way.
I know.
Want the Dusty Muffins at your next event? We do panels, live podcasts, and talks that bring the heat, literally. Corporate, CME, or retreats, we've got you. So hit us up at thedustymuffins333@gmail.com or DM us on Instagram at thedustymuffins.
I was just thinking about, I'm like still back here thinking on what the whole, like what you said, Rebbecca, about, climax first, have your orgasm, and then your vagina will be better ready. And I'm like thinking to myself, damn, I could do without, like I could be done after that. I'm like, maybe I need to rethink myself.
I think it feels better afterwards.
Like,
and then to my patients, I'm like, and listen, and then if you decide you go for two, like during, like with your partner, even better.
I'm gonna rethink the whole when I'm
let me know.
Gotta go.
Try to let us know. We want to know.
No, I'm gonna rethink myself. Look, I just got my vagina ready. All right, here we go.
Let's go. I'm like, let's go, sir. She gonna be chasing Drew all over the place.
Poor Drew. Poor Drew. I hope my parents don't listen to this podcast.
So I love that you make anatomy so like front and center, kind of like we were talking about, because so many women are socialized really to do the opposite. And I think we've all, experienced that with our patients, but, to stay quiet and accept dismissal. How can patients effectively, advocate for themselves in a clinical setting without feeling like they're burning the bridges with all their providers, practitioners?
I think you kind of have to come to a point with yourself where you're like, all right, at the end of the day, who is this appointment for? And it's you. So it may be uncomfortable, but if you want to get better, if you want change, if you want answers, you have to go in and, and be there for yourself and tell them what you need. It doesn't, I don't think it helps to go in guns blazing and, accusatory or any of that stuff, because a lot of, I think, clinicians would be open to the conversation, or at least open to say like, hey, I have maybe not been the most educated in this aspect. Let me see if I can find somebody for you. But unfortunately, nobody else is going to do it for you. So you really have to get out of that mind space of like, I don't want to offend anyone, but they've also been so helpful for, I had my babies through them and this and that. And like, great, that's wonderful. We love them for that. But you got to do what's right for you. Nobody else is going to do it.
Yep. And I think clinicians need to just start asking, like your patients, you would be so surprised, whether it's GYN, women's health, primary care, ask the question, ask those questions. It's so many, and I'm sure with all of us, they're just like, no one has ever asked me that. Thank you. I thought something was wrong with me, or, whatever. It just is so important just to ask the question so your patients feel seen and heard, even if you don't have all the answers.
I know, but I also get it from the clinician point of view. I think a lot don't want to ask because they're like, oh God, please, how are we going to answer this? I don't have an answer for you. I don't know how to do this, or I don't have time. Yeah.
I don't have the time, right?
So like, I understand how we've gotten here, but it's still not okay.
Well, and I think too now, right, now that more clinicians are like, I got something, I got a tool. Because if they don't know anything, they know vaginal estrogen. Like we've been hammering that down. And I think 99.9, maybe I'm overstretching, should be doing, they're comfortable with vaginal estrogen. But then, they really, many are what I call a one-trick pony. So then what happens when the patient comes back and says, well, I'm doing that, but I still have pain with intercourse. So let's get into the nitty-gritty of pain with intercourse. When what do you do when a patient tells you it just hurts? What is running through your mind? Walk us through your clinical approach and your list of differentials. How do you narrow down if it's skin, the nerves, or the muscles? Because let me tell you, clinicians who are prescribing vaginal estrogen are hoping, that 99% of patients never come back with that complaint again. So how would you break that down?
Yeah. So lots of initial questions like, what are you doing when it hurts? What is it just during sexual activity? Is it other times? Is it with penetration, but it's only like at first we're like, ooh, that feels too tight, that doesn't feel good. Is it a deeper pain? Is it a dryness? Does it feel like glass burning? Whatever. Are there other associated symptoms, urinary symptoms, constipation, you name it? So we kind of go through the gamut to see what other potential things could be going on. And if you're someone who you're like, all right, that's my trick. We used estrogen, didn't work, and it didn't. What I see a lot of times in perimenopausal, postmenopausal women is it takes so long for someone to finally give them the vaginal estrogen that, like, yes, their skin feels better, but those muscles have been subjected to pain for so long that now they've learned to just get clench, 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 and they're not just going to let go. Like, now we have pain, stemming from the musculature, whereas if we had really treated this early on and just given the vaginal estrogen when we should have, we would have been fine. So, I mean, my exam is not rocket science. I'm like, there's kind of three parts to this. I use my eyeballs, just look. I use my little Q-tip around the opening to see if there's pain at the vestibule, and then I use my finger and just press on muscles. Like, that's it. So, it's not, it's the simplest, dumbest little things, but it can give you so much information. So, if you come back after your estrogen and their skin, they're like, yeah, no, there's no pain there. But as soon as you put a little bit of pressure down with your finger, well, we probably have some muscle involvement there.
Mm-hmm. What are you looking for? What are your eyeballs? What are you honing in on?
The clues that, well, half the time when somebody tells me their story, like you guys, I'm sure you're like, I think I probably already know what's going on here. So, confirmation. Do we see the signs of menopause? Like, oh, their clitoris looks a little bit smaller. Their labia looks smaller. that thinness, where you can see the little blood vessels coming through. And also making sure there's no other dermatological conditions going on, like lichen sclerosis, lichen planus, anything else obvious that I'm like, oh, we should address that as well. But usually fine.
I find sometimes if I'm doing a PAP and you just go to let them know that you're getting ready to touch and their bottom already goes up to the sky, I often that will spark a conversation too. Like, do you do that during intimacy and intercourse, right?
Yep.
And they don't even realize it. And so their brain has already correlated that, like, touching the vulva and, is making them already start to kind of clench and, like, get protect themselves, that part of themselves. Yeah.
We do a lot of education about pain, and so many women are like, no, I'm not in pain. I'm like, all right, well, I'm going to tell you what I'm seeing. Your toes are clenched. You're no longer breathing. My little fingers are like fighting for their lives to try to get from there. Like, you're strong. Yeah. You're giving my hand a cramp. I was like, I'm sensing a lot of things here. So how are you actually feeling? And then they're usually like, well, I guess there's a little discomfort. I'm like, discomfort's still pain. Like, we can name this. It's funny because they always tell us, like, you believe whatever a patient tells you, but with pain, I'm always yelling at them. I'm like, it hurts more than you're saying.
Well, that's because we just are trained to just tolerate, right? We tolerate hot flashes, we tolerate shitty sex, we tolerate, pain with intercourse, which makes it, like
bleeding every month for our whole lives, cramps.
Right.
Yep.
Oh,
no more.
And not learning how to relax the pelvic floor. I think, like, when, again, when I go back to just doing a pelvic exam, if I can walk a woman through, I want you to relax your bottom into, that table and kind of work through that. A lot of times they can do it. And, and that, I think, is that where you decide whether or not, pelvic floor PT, because I know we want to talk a lot about that too. Are they able to relax? Do they know how to use those muscles to relax them? Because that makes just the pelvic exam so much more comfortable, quote unquote,
I'm a pelvic floor physical therapy groupie. There's like pretty much no one I wouldn't refer to physical therapy. I'm like, even if you're not having symptoms, I feel like there's something you could just learn from them that would prevent future things that you'd be like, I didn't know that. Yeah. But there's literally almost nobody I don't refer to them. There's always room for improvement.
They did. After my last baby, I did pelvic floor PT, and it saved my life, let me tell you. Because Jackson was so traumatic, and I just was like, I can't hold on to anything. Yeah, it was amazing.
They're little
So,
unicorns, our pelvic floor PTs.
mhm.
And Andrea, you have your own private telemedicine practice. And when you're talking to someone about pain via telemedicine, how do you do that? Do you direct the patient through a self-exam to get the information you need, or how do you do it?
We could do it either way, honestly. Again, it's not that much different, crazily enough, than the in-person visits, where the majority of the visit is me listening, them talking, and me putting the pieces together and being like, okay, I have a feeling there's this, there's that. Um, do I then have the physical piece where I can confirm what I'm hearing? No, but a lot of times it's enough where we can kind of start on that process and I can give them a really good roadmap. And then, of course, if that's not working or they're running into other things, and it's like, no, we have to get somebody in there to actually look. But it's listening.
Yeah, I
The body
agree.
tells you.
I have people ask me all the time, how do you do it through telemedicine? But it's so easy because, like you said, it's basically me sitting here and my patient telling me everything. And all I have to do is listen to them and believe them.
Yeah.
And I think it lends itself to talking about, do you have a mirror? Have you looked? Is anything, look white? Does anything look short? Do you have any little, red balls outside of your clitoris? Like when you, not your clitoris, your urethra, right?
What are we
When you
talking
have,
about now?
I had to think about where is it going,
Where are
but
these clitoris balls?
from the urethral prolapse, right? So
Yes.
I think nobody looks. Everybody should be looking.
I was just going to say that if anyone's listening, I would encourage everybody to get a nice little handheld mirror and either, lay down, take a look, like know what your anatomy looks like.
Yeah.
Because if you don't know, it's almost like when we tell women to do self-breast exams. Like I still think there's value to that. If you don't know what's abnormal, you can't tell me. You don't know what's normal for you. You can't tell me when something's abnormal.
Yeah.
Right. And I think that's with anything on our body. Like when you're doing a skin exam and you see a mole that you've had forever, and if that thing has changed, or, we can extrapolate to men, if, they're doing even self-testicular exams and it's abnormal, something's abnormal, it's because you know what your normal is. So for women, we need to look, we need to know what the vulva looks like, what is normal. And you can either, have one leg up in the shower with your hand held, or stand over it, or lay down, do it with your partner if you want to, and just, it's so important. But again, it's just, we've been taught we should just not, we don't talk about it, and we certainly don't look at it.
Oh, we are looking. And I always break out my models. I think I only have Helga's behind me too. I have Mary, she's the vulva. She's quite involved. Dolores, she's my other clitoris.
Dolores.
Helga. There's Helga and Olga, they're sisters. They're both pelvic floors. One has the organs inside, one doesn't. So I find that
name them.
Well, I mean, they're very
I love that.
integral part to my practice. They deserve.
I know. I need to name her. Like she needs.
I know. I
They're
need
so
one
beautiful.
like that.
She
I
needs
have
one.
mine.
Maybe we'll just call her Bella.
Oh, I like that. I need a pelvic floor. I would like to have that.
It was making me think of like how you have stop, drop, and roll if you're on fire. Like I was thinking about it was just going through my mind. I'm like, we need like a mnemonic for like checking your vulva. Like, I don't know.
Stop,
something flip and touch.
Oh, I like that, Christine. Yeah, we should come up with something.
We need to come up with something, right? Like
stop, drop, and lift.
Oh, we're getting
spread them, not spread them.
Something about magnify, like some magnify. Like we need that's going to be our thing. The four of us, we're gonna put that into a mnemonic. Like
I love it.
So you can remember.
I like it.
So it's going to be a national sensation.
Though that was very nice yoga move there.
It was. I'm like, I
You're
cannot
listening,
even
you
do
need
that
to
at
see
all.
this girl put her foot over her head. That was very impressive, Andrea. Very impressive. So one specific cause of pain with intercourse we wanted to highlight, because I think this is something that neither many clinicians don't realize and many patients, is clitoral adhesions. And for those that may have an adhesion, how do they present? What should someone be looking for during a self-exam? Because I think a lot of people don't know about, like, they just think the clitoris is just a bump, right?
Yeah, so I guess we should go into anatomy a little bit first. That basically, and I'll do my best to explain since
You
this
can
is
use
a
a model if
podcast.
you want, because
I
it'll be
know, but
on
it's a
YouTube for
podcast
people.
too. Get
Yeah.
down here, girlfriend. Okay, who's
Oh,
this?
Who's
Who is
coming,
this?
So,
Dolores or
yeah. Who's
Mary? Or...
coming to the show?
I mean, this is Dolores.
Oh, Dolores.
Dolores'
She's so
sisters.
beautiful.
She thinks she's
Pretty.
beautiful. But normally, your clitoris, you could only see like 90% of your clitoris, or 90%, 10% of your clitoris. 90% of it is buried underneath. So if you picture your head as the head of the clitoris, and if you're wearing a hoodie and you've got a hood over it, that's the hood over the hood of the clitoris. That is what we can see on the outside. So sometimes what happens is that this hood kind of gets a little attached. It gets stuck, and it should be able to move back and forth. But if it can't, you can get some schmutz stuck up under there. So we can get smegma, so like dead skin cells and oils and things like that can build up and form these little things called keratin pearls, which are like little hard, like grains of rice or sand. They come in all different sizes. But they can cause pain, and you can have different degrees of adhesions. So like it can just be like a little stuck on the sides, or mostly stuck where you still see a little bit of clitoris peeking out, or you can have like completely closed up, like we cannot access your clitoris from the outside whatsoever. So it would, and this again, this is something that gets easier to identify for actually looking at your own body some more. There's also pictures, there's a few studies out that actually show pictures on real human beings, which I think helps for identification as well. But yeah, it can just be that sensation of either something you see that you're like, oh, that's definitely stuck on there. And other sensations can be like change in orgasm or sexual function. Like I've heard people say it feels like I'm trying to like have an orgasm through like a heavy blanket or something. Like that sensation is really dulled. Or now it's too sensitive, where it's something that used to feel really good. Now I'm like, hypersensitive. I don't like that. Get away from me. I actually had a patient in her 90s who she kind of had a little compilation of PGAD plus clitoral adhesions, because she had this. It wasn't even a keratin pearl. Like this was a full-on rock that over time got stuck underneath the clitoral hood. And she kept saying to her doctors, like, my clitoris is getting bigger. My clitoris is getting bigger. And they're like, no, it looks fine. It looks the same to me. She was
Or
so
did they
cute.
even look at it? Mm-hmm.
Yeah, exactly. And she's like, every time, she's like, I ride the bus around the city, and every time it hits a bump, like, I feel it. I feel my clitoris, and I don't like it. She's like, and my lady friends tell me that sounds very nice, and they wish that happened to them. But she's like, I don't like it one bit. And I was like, I know, it's not the right time. You don't want it.
Right.
But she had some pretty bad adhesions, and this, like, it's called like a smegmatic pseudocyst was underneath there. And it's like, well, gee, you felt a lot better once we got that thing out of there. So like she was aware, like what she saw as her clitoris enlarging was actually this cyst underneath that was expanding and getting bigger and bigger. But it's just another reason why it's so important to look.
And tell us, like, what women should be able to do with their clitoral hood, or even what physicians should be able to do as far as, like, should be able to be pulled back, and why that's so important, especially for arousal too.
Yeah, it's basically, it should be movable. It should be freely movable. So it's kind of like popping a pimple when you go in, because you're kind of pushing up and back. And as long as that hood can move freely, then it's good. So as if you are aroused and there's more blood flow and things are swelling, there's room to move. It's not going to feel restricted and tight and painful.
And I kind of will say, you know, I feel like we all know about foreskin in a male. And so I think that a lot of people can visualize that sometimes maybe a little bit better, unfortunately, than their clitoral hood. But, you know,
Yeah,
that pulls back too, right? During arousal.
absolutely.
And if they're cleaning themselves, they should be able to pull that foreskin back. So would you say that it's comparable to that just for visualization for
Yeah,
women?
it's just about the exact same thing. Like, we don't officially know yet, you know. I feel like there's better rules with foreskins about like how often you should pull back and cleaning and this and that. We don't really have those official rules for women. It's kind of like just make sure you can get it back, and if you see anything stuck under there, you can, you know, get it out. But some people never have that experience and they're fine. Other people, you know, produce more material under there. So it's we don't have those hard and fast rules.
Feeling off in midlife? I'm Dr. Rebbecca Hertel, and I offer concierge telemedicine across multiple states focused on hormones, weight, libido, and sleep, and longevity. Let's get you thriving. So visit www.osteopathicmidlifehealth.com.
I was going to say, once you've identified then, you and the patient, that there is something there, or the skin, the hood is now adheres to the clitoris, what are the treatment options? How do you go about fixing that?
So honestly, the most common option is doing nothing. If they have no symptoms, if they're like, no, orgasm's great, I'm not having pain, leave it. It's your clitoris. We don't have to go poking around. Like, we're aware of this now and we can monitor it, but it doesn't mean we have to do something. But if it is bothersome, if they're very mild adhesions, some people have good luck with just kind of manipulating themselves, even working with a pelvic floor physical therapist, you know, using your topical hormones. If you also have another condition like lichen sclerosis where you need a steroid, I find most people aren't that successful at it. You usually need something called a lysis of adhesions, which is just something that we do in the office. We numb your clitoris either with topical, like a really strong topical, or we could do a dorsal clitoral nerve block. And then we literally just separate the skin. You don't have to like cut, or it's just literally like boop, boop, go in and separate. And that's it.
That's wonderful.
Yeah, it's pretty darn easy. Now, it can recur. I would say, depending on the study you look at, it could be somewhere from like 20 to 40% of the time that it happens again. So it is important to, once you do have that procedure, to keep kind of moving your clitoral hood back every day. We use like Vaseline or Aquaphor to kind of keep things slippery. But again, if it's not bothering you, you don't have to, you know, don't panic if you're like, everything was fine and they told me to look in the mirror and I see an adhesion. If everything's okay, leave it.
Will their use of vaginal estrogen help keep them from recurring? Or is it not enough? Or sometimes
No, I think for a lot of people, it can be either vaginal estrogen or estrogen plus testosterone. You know, it kind of depends on what was the cause of it in the first place. And even that, we're still on the forefront here of understanding some of that stuff. But yeah, I think that can be very helpful.
Yeah. Christine, did you have a question before?
No, I forget.
Sorry, Steve.
Good.
Let me know if you remember.
And it's
So
done.
I guess kind of talking about compounded, you know, when do you choose to use progesterone versus like compounded estradiol and testosterone cream? And then what are the specific signs that tell you which like recipe you would choose for a patient?
I mean, a lot of it comes down to cost. At the end of the day, it doesn't matter what I give somebody if they can't afford it. It's not going to help them.
Right.
So kind of figuring out, okay, can we actually get the progesterone and the Introsa covered? You know, is it actually cheaper to get it compounded? The Introsa is one of my favorites, and it's amazing, but it does go in your vagina, but it's very melty. So if you're someone who's comfortable, which some people are, I'm like, once you let it kind of cook in there for a minute and it's melty, you just kind of rub it all around your clitoris. Other people are like, I'm not really a fan of that. So then we'll just go straight to a cream, since they can put that right on their skin and not have to wait for any melting to occur.
And I think it's important to know, like for patients, that the testosterone gel that they're using for their libido is not meant for their clitoris in their
Yes.
vulva.
That'll burn.
That'll burn. You need compounded.
Yes. She will not be happy with you.
No, there's alcohol in that. It hurts.
Can we ask you a little bit about painful bladder syndrome, Andrea?
No.
Do you see a lot of that?
I do. I see that a lot, but honestly, I think, and I don't know about you guys have come across this, a lot of the painful bladder syndrome is actually genitourinary syndrome of menopause or vestibulodynia.
Yes.
It's not the bladder, it's the skin right around the opening of the vagina.
Yeah.
So I think we went wild diagnosing people with that, and we got it wrong, myself included.
Yeah. Or oral birth control pills. I'm seeing those trickle in just a little bit more with some some vaginal dryness associated with that. Yeah.
Yeah. And,
So important for everyone to make sure that they're letting their young women know about this and keep it on your differential.
Oh, yeah. So what we're saying is when you go on the birth control pill, sometimes as that gets metabolized in the liver, it increases a protein made by the liver called sex hormone binding globulin. And that can go around and bind up all your free testosterone, which is the type of testosterone that should be doing its work at the level of your tissues, which can give you symptoms of genitourinary syndrome of menopause. So even young women on the birth control pill can have a vulva and a vagina that look menopausal.
And breastfeeding women too.
Breastfeeding,
It's so painful. But if of course there are still people who we go through all that and we do the hormones and it's like, okay, no, this is actually your bladder is communicating with us as well. It's funny, the focus used to be very much diet focused, like eliminate everything from your diet. The diets these people were put on were so restrictive. And I remember, because I worked at one urogyn office for like almost 6 years. So I remember having conversations like, do you actually feel better? Like, we tell you to do this stuff, but is it helping? And they're like, no, not really. Because I think that really is a small percentage of people that the pain's coming from like the inside of the bladder, that they're really, irritated from cranberry juice or, orange juice, all those types of things. I think so much of it. Exactly. I was like, I really think we're overdoing this and restricting and taking away the little joy people have for minimal relief. I think a lot of it comes from the skin, a lot of it comes from the muscle, and so much relief can be had from between topical hormones and pelvic floor physical therapy.
It'll be interesting to see if, over the next 5-10 years, if interstitial cystitis diagnoses start to decrease.
Yeah. Because this is like I said, I worked in urogyn and I was like, I feel some of these patients, you're with them for years. And I've always, I feel like patients a lot, they want to please us. They feel bad because they know we're trying. And I'm like, tell me the truth. Like, I'm seeing what's going on here. I don't feel like I've helped you that much, between the bladder installations and the Elmer and all these different things where I'm like, do you actually feel better? And they're like, not really. I was like, we got to come at this from another angle. We're missing something here.
Yeah, absolutely. I was talking to someone who's like, I have interstitial cystitis. And for whatever reason, she thought she couldn't be on vaginal estrogen. It was a friend, not an associate, not a patient. And she's like, I just have to watch everything that I eat. And I'm like, you're in your 60s. You really need some vaginal estrogen. Then you could probably eat tomatoes again.
Yes, exactly.
I think you'd probably be okay. So shifting gears to relationship, let's talk a little bit in our last little bit of time here about low drive and high drive partner mismatch. And, that causes so much guilt, mostly for women. And then how do you approach the mismatch from a medical perspective? How do you, with your patients?
I always make it clear that this is, while it's not a medical emergency, like you get to have the say at the end of the day of what you want to do about this. It is a quality of life thing. And it's not, I feel like the way that this is viewed in society is it's like, the problem is the person with lower desire, and now they need to kind of get better so they can match to the person with high desire. But I'm like, no, if this is a couple, everyone's involved. It's really about how do we meet in the middle so that, this person doesn't feel pressured and like they're being pawed at constantly. You know, this person doesn't feel neglected. And at the end of the day, it's like, these are the treatment options we have. We can do medication, we can do sex therapy, all the things. Like, do you want to do that? Do you think that is something that will add to your life, add to your relationship? And for a lot of people it is. And for other people, once we just have the conversation, they're like, no, actually, I think I'm okay the way I am, especially when we have the conversation about like responsive desire versus spontaneous. When you explain to someone how, most women, our brains don't kick in and they're not really interested in sex until we're physically aroused. Quite a few women are like, oh, okay, I'm normal, then I'm fine with that. We're good. I don't need anything else. But there's also plenty who are like, no, I'd like to see what else we can try.
Mm-hmm.
And
it makes a big difference. They feel like a sense of relief. They're like, oh, I'm like, yeah, I don't ever want to do it either. And then 5 minutes in, I'm like, oh, all right. This might be a little fun.
Like, oh wait, actually I do kind of like this. But
once you figure out you're normal, I mean, it's because we think there's something wrong with us that we have these worries, And
I had an interaction with a couple the other day, and it was so lovely, and I honestly think that it was because one of the partners is trans, because the conversation that was had, like one person had low, one person had high, and the person with high desire was like, honey, do you think I feel like you think there's something wrong with you. I think you have a high, a normal, healthy desire, but I think you feel pressure because mine is more, or because you're taught this. And I was like, these are the kind of conversations people need to be having. Like, I just love this. This is beautiful.
So true. And it comes just down to educating about desire, right? And what is normal. And that just, we all use the food analogy. Just like you may like pizza and someone else likes lasagna. They don't want to have pizza all the time, or what, Yeah, I mean,
I think it's okay.
It's okay.
It's not, doesn't automatically mean there's something wrong with you. People are just different. But if that different is causing, it causes strain for a lot of relationships or individuals, then we do something about it.
And we have people on medications that really affect your libido as well. And often you're put on these medications and you're not told. For instance, some of the antidepressants that we use, we love antidepressants. They work brilliantly and they can save lives, but they can really affect your libido.
Or your ability to climax, right? And I feel like we tell men all the time, I'm going to put you on Zoloft. We put them on that on purpose to help if they are climaxing too quickly. But we forget to tell our women, hey, this may inhibit you. Where you're getting up the hill and you're on the hill, but you're not going over that hill. You just get up there and you just stay up there.
It's not fun. But no. I do find it ironic how a lot of times it's women have the onus to pregnancy prevention. So we all have to get on birth control. And again, I love birth control. That can affect your libido, all this mood stuff. We'll give you SSRIs and this and that. And then it's like, why don't you have a libido? What's wrong with you? And it's like, hello. Then you add in the mental load and all the things. And it's like, why? It's amazing when women do have libidos.
Right.
Yeah. all the other things, right?
All the
things. Kids, the groceries, the work.
Just stacked against us. I know. And then society's like, what? Why aren't you so
excited now you're gonna look
to my penis?
Yeah.
I know.
Yeah, I think it's important, for women, if they're comfortable with their libido, don't feel so pressured to feel like you need to change it, right? Like, because we always ask, do you have decreased libido? And some people are like, I'm good with it, and then other people are like, no, it's really distressful. And if you're good with it, you don't have to make it distressful just because all we talk about is testosterone and increasing it. If you don't want it increased, then
no, don't do it.
Go forth and conquer.
I know. The area where I almost feel like it gets a little gray is when I talk to a patient who says, like, I'm not bothered by it. If I wasn't in a relationship, I could care less. But I'm in a relationship, so this is an issue. And it's tricky because, you never want anyone to feel pressured or forced to make these changes. But at the same time, you understand how important a relationship is to somebody. So trying to walk that line of here are these options for you. We could do this, but I'm not trying to shove this down your throat here either.
What a great way to like I think that was a perfect way to kind of end our podcast.
Yeah, I do too. And thank you so much for being our sexpert today and for the wallpaper. I absolutely love it.
Now let's all go play in the snow.
Andrea, why don't you tell our listeners where they can find you?
Yes.
Find me on the gram. I'm on Instagram all the time. It's Andrea Sexplains It All. And then my website is glowhealthbyandrea.com.
Yeah, because and if you're in Pennsylvania, New Jersey, or Maryland and need an expert who truly gets it, you need to look up Andrea. And you can also see her rescue pets and her incredible collection of sex health toys. Andrea, thank you so much for joining us on the Dusty Muffins today.
Thank you.
Thanks,
for having
Andrea.
me, ladies.
Thanks so much, Andrea.